So with tension headaches, the big thing that's going on there, it's stress. Right? So the major stress that's going to be happening, it's usually like stress in the face, also stress in the shoulders, right? If you're like you have poor posture, you're like hunching your shoulders a lot, that can eventually start putting stress on the muscles of the head as well. So when you get that, you get this kind of feeling of a tight band around the head. And you can get that from, like I said, stress, tension. You can also get that from wearing glasses, like I do. And then if you have any sort of misaligned teeth or jaws, that can also cause tension headaches too. So if you are getting like your cavities filled and they like filled it a little bit too much, and now you're not getting like a nice even bite, that can eventually start causing headaches as well. So all those things can cause tension headaches. And cluster headaches, we already talked about. I'm not going to play the videos again, but cluster headaches, those are your suicide headaches. Extremely painful. So painful that some people literally just knock themselves out so they don't have to experience the headache anymore. So very debilitating and not a good situation to be in. You get unilateral pain with a tension headache. Sorry, with a cluster headache. So it's going to be around one affected eye. You get multiple times a day sometimes. You will start seeing things like tearing or lacrimation, runny nose, swelling eyelids, drooping eyes as well, so you get ptosis. And then how do you treat it? You want to reduce the amount of light stimulation so you can blindfold the person, and you can also give them oxygen to be able to treat it as well. So did we already watch this video? I don't know if we did. Yeah, you didn't watch this video. All right, so you guys get the idea, right? So pretty horrendous stuff. And then the hitting of the head, I mean, that's kind of to distract from the actual pain, right? So one way to maybe try to relieve it. It's kind of like that guy who said that he literally knocks himself out so that he can try to avoid the actual pain itself. So horrible stuff. So that's cluster headaches. And then this is where we closed off last time with migraines. So with migraines, it's going to be involving a couple different things, right? So vasodilation, vasospasms. So you get a combination of the two. If it's vasodilation, that's why we closed last time talking about caffeine and how a lot of migraine meds will have caffeine in it, because part of caffeine, its effects will be to vasoconstrict. So if you have too much vasodilation, that can cause a headache. So you might want to try to vasoconstrict those vessels to reduce the headache. 5-HT, that's serotonergic receptors. So if you have not enough serotonergic activation in the brain, that can also cause vasodilation. So certain drugs, for example, like sumatriptan, so the triptan drugs, those are going to be serotonergic drugs. So they actually affect 5-HT receptors in the brain. So sumatriptan is one of the most commonly used migraine medicines out there. And unfortunately, it's going to be most common in women. Now, the things that you'll see with the migraine, you get nausea, vomiting, you get photophobia, so you don't like to see lights. You also get phonophobia. Phonophobia means you don't want to hear noises. So a person who has a migraine attack, put them in a nice, dark, quiet room until it's over. Right? Usually that's going to be one of the best ways to treat it, along with the meds as well. So you want to give them drugs like sumatriptan. And there's a whole litany of different meds that can be used for migraines. Some that are like pharmacological, what's it called? Sumatriptan. But then also there's some naturopathic type meds that can be used as well. Herb butterbur is one that I've heard could be used that can actually be pretty effective against migraines. So if you go on like WebMD or any of those websites that talks about different treatment options for migraines, there's a massive list of different drugs that can be used as well. So what happens when you get a migraine? So usually you're going to see, well, not usually, it's rare cases. 33% of cases will have auras. So kind of similar to what you see with seizures. You get almost like a prodromal type effect. So you get the aura, and the aura is going to involve all sorts of weird hallucinations. So it can be smells, tastes, but very common you'll get visual scotomas. So if you get these blind spots, those are called visual scotomas, and those are blind spots. You can get shimmering spots as well. You can get flashing lights, zigzag appearance. And then migraines could occur in kind of like clusters, right? So they can be cyclical. You might get a couple a week, and then you get a period where you don't have any migraines. But in terms of cure rate, you're not going to get a cure for migraines. People who get migraines will get them periodically. And then you can, of course, take drugs that help to treat the symptoms of the migraine. You can take drugs that prevent the migraine from coming on, and you can also use rescue drugs that when the migraine does happen, you can use those drugs as well. So I think sumatriptan is used as a rescue drug, but there's other drugs that can be used as preventative mechanisms as well. All right, so caffeine. Caffeine, of course, is a vasoconstrictor. That's one of its effects. It does other things too. It's going to block adenosine receptors. That's why over time, throughout the day, you get adenosine buildup after you're undergoing regular day-to-day activity. Right? Adenosine is going to be one of the components of ATP. So it's adenosine triphosphate, right? Adenosine diphosphate is ADP. Adenosine monophosphate, AMP. And then when you have buildup of adenosine over the day, that's why you get tired. The adenosine is going to bind to adenosine receptors, and that's what makes you sleepy. Caffeine blocks adenosine receptors, and that's one of the reasons why caffeine can help increase alertness and increase how awake you feel. Other things that caffeine can do, caffeine actually does operate as well on dopamine, so it can actually give you a euphoric effect. Epinephrine is also going to be seen with caffeine, so you get that vasoconstrictive effect with alpha-1 adrenergic activation. And so as you vasoconstrict, that can help to prevent worsening of migraine symptoms. That's why you see a lot of meds will contain caffeine with them. So Excedrin is a good example. It's going to contain caffeine with it as well. Triggers for migraines. Attending Dr. O's lecture. Lack of sleep or too much sleep can be things that trigger migraines. So any sort of disturbances of your circadian rhythm, sleep-wake cycle will affect migraines. Meals, if you skip meals, that can be something as well. Noises, for some people, even strong odors can trigger a migraine. Hormonal changes for women, especially during menstruation. Stress and anxiety, weather can be a trigger. Alcohol, the tyramines in red wine can affect migraines. Caffeine, too much or too little. Caffeine withdrawals, right? You can get withdrawals from caffeine. I drink caffeine like all the time, at least once a day, sometimes twice a day. If I skip a day and I don't have caffeine, I get vasodilation, right? And so the vasodilation is what causes a caffeine withdrawal, and that's what causes a headache. And so for people who get migraines, that can trigger a migraine as well. Nitrates, foods that have nitrates in processed meats, MSG, another thing that's found in food. Other things that have tyramine, so cheeses can have tyramine, fava beans, fish, and of course Chianti, red wines, and then aspartame. The tannins in red wine can also be something that can cause migraines. So tannins can affect the serotonergic receptors, and if that happens, that can also affect migraines too. So tannins, do you guys know what tannins come from? Huh? It comes from the skins of the grapes. So red wines in particular are going to have high amount of tannins. Not so much white wines, because white wines, it's just the juice. Whereas red wines, they're aged with the skins, and that's where you find the tannins. And tannins are what give red wine the astringency. So when you drink a glass of red wine, it kind of puckers up a little bit. So that's the tannins that cause that effect. But tannins can affect the serotonergic receptors as well. So migraine versus tension headaches. So tension headaches, you're going to usually get both sides of the head. So it's bilateral. It's going to be dull, kind of an achy feel, right? Like kind of like the band tight around your head. Versus a migraine, usually it's going to be unilateral and it's going to be a throbbing type of pain, right? The throbbing pain is going to be associated with like the blood vessels, for example. Don't worry too much about the duration because the duration can vary, and so that's not really going to help much. But generally speaking, tension headaches can be a little bit faster, but migraines tend to last a little bit longer, but they can both last a long time anyway, so that's not going to really help you. Knowing that migraines are unilateral versus tension headaches, which is bilateral, that's going to be a really good way to differentiate between the two. All right, any questions on headaches? Cool. All right, so let's talk about hematomas. So hematomas, of course, that's where you have blood pooling up in different parts of the brain. And there's two major types. There's going to be the epidural and subdural hematomas. So we'll talk about the differences between those two, how they present clinically, and usually what the underlying cause is. But generally speaking, with hematomas, fractures are going to be very common, as well as trauma. So trauma, you get different types of hematomas can arise from trauma. And skull fractures. Skull fractures can also increase your risk of hematomas. And then berry aneurysms, we already talked about those already when we're talking about vascular issues, but know that if you have a ruptured berry aneurysm, that's going to be associated with a subarachnoid hemorrhage. Okay? And berry aneurysms are going to be mostly seen in the circle of Willis, right? And so you have the kind of weakening of the vessel wall, then you get the ballooning of the vessel, and if that vessel bursts with a hemorrhage, then it's going to be a subarachnoid hemorrhage. Symptoms: worst headache of the person's life, and nausea and vomiting, so the person's also going to be vomiting a lot. And depending on the severity, you might see neurological deficits that look a lot like stroke. Now, epidural versus subdural, it's good to kind of know the speed that you're going to see the symptoms. Epidural hematomas are going to be very fast. Subdural hematomas are generally going to be slower than epidurals. That's one way you might be able to distinguish between those two. Signs and symptoms: headache, nausea, vomiting, changes in vision, speech changes. You might see unilateral hemiparesis, seizures potentially. AMS is altered mental status. And then, of course, if you want to be able to see exactly what's going on, a CT scan is going to be one of the best ways to do that. So you do a head CT scan of the patient. All right, so let's go into the different types. So epidural versus subdural. Epidural is mostly going to involve arteries, and it's going to mostly involve the middle meningeal artery. Then it's going to be usually fast. So the person might have like head trauma. After the head trauma, you're asking the person, "Hey, are you okay? Do you know where you are? Do you know what time it is?" You give them like kind of like a field type exam, right? Ask them what their name is, things like that, right? Just to see if they're cognizant and lucid. And sometimes they might be okay for a little bit, but because these bleeds happen really fast, you have that lucid interval, and then suddenly the patient decompensates rapidly. And so that's why you can have a phase of lucidity, and then they die shortly after. So that's why it's called talk and die syndrome. They're talking, things are fine for a second, and then all of a sudden they decompensate rapidly. If you were to do a CT scan, it's going to be biconvex. So it's going to look like a lens. So think about like the lens in your eyes. You can kind of look like a lens where you have a biconvex shape. What's up? How long does it take? It really depends on how bad the bleed is. So it could be minutes. It could be maybe like 5 minutes, and then all of a sudden they just decompensate. So it really just depends on how severe the injury is. Versus subdural. Subdural, instead of arteries, it's going to be veins, and it's going to be the bridging veins. And with a subdural bleed, it's going to be generally slower, and it's going to look more like a crescent moon shape. Okay, so instead of a biconcave lens shape, you're going to see a crescent moon shape. And epidural, that's going to be above the dura mater. Subdural is going to be below the dura mater, and it's going to be between the dura mater and the arachnoid mater. Okay. So epidural, so that's going to be a biconcave shape. This image doesn't really give you a good depiction of that. These both look like epidurals, but it demonstrates where it is in terms of like its relationship to the dura mater. With an epidural, as the name implies, above the dura mater. Subdural is going to be below the dura mater. But in reality, this would look like that, right? So it's got that nice little biconcave lens shape. But this one would look more like a crescent. The bleed would go down a little bit further, and so you would see a better distinction on a CT scan. Epidurals, generally it's going to be due to a fracture. So blunt trauma to the head, you have a skull fracture, then you get a bleed, especially if it's around the temporal bone, where you hit the middle meningeal artery. You can also see this happening with veins too. So it's not just arteries. It's mostly going to be the arteries, but sometimes you can get veins involved in that. But bottom line, the most important location is going to be, distinguishing the location is going to be important, right? Epidural above the dura versus below the dura mater. Then, as I mentioned, you get that lucid interval. And then as the bleed gets worse, you're going to start getting compression of the brain from the bleed. Right? The compression is what kills the person. So the compression is going to cause a herniation. When you have a herniation, it's where you have one section of the brain getting into a compartment of a place where it doesn't belong. Right? So there's different types of herniations. There's a tentorial herniation, where you have a herniation from the area of like the cerebral cortex down towards where the cerebellum is. That would be an example of a tentorial herniation. But there's different types of herniations. I'm not going to make you responsible for all those, but know that when you have herniation, that's usually what kills the person. So here's an example of some blunt trauma on a patient. If you were to remove the bones, then you would be seeing underlying bleed, right? So this is going to be an epidural hematoma. So this is above the dura, and there's the middle meningeal artery that was involved in that incident. Subdural hematoma beneath the dura mater, and know that when you look at it on a CT scan, it's not going to look much like this. It's going to look more like a crescent moon type shape. Generally, it's going to be involving bridging veins. And there's different types, acute, subacute, chronic. And then one of the biggest things that you see that's causing severe damage on these patients, again, you're going to see herniation with these patients too. So you'll see one part of the brain entering into a compartment that it doesn't belong in. And that's what causes some of the more severe symptoms as well as death. And you also get increased intracranial pressure from all that bleeding. The pressure is going to accumulate, and it's going to increase intracranial pressure. Yeah. You're going to get shifting of the brain into different areas where it doesn't belong. So that's what a herniation basically is. Kind of usually a shifting, moving of the brain. So. Yeah, you would see that because hydrocephalus would cause increased intracranial pressure. But hydrocephalus generally doesn't kill the patient, right? This will kill the patient if left untreated. But yeah, very similar. hydrocephalus, you get extra fluid accumulated in the brain, and that causes a lot of pressure on neuronal tissues. But like I said, usually doesn't kill the person. Headaches, drowsiness, agitation, all the cardinal signs of altered mental status. You might see respiratory involvement and then pupillary dilation as well if you're affecting those neurons. So subdural hematoma, you're going to get movement of the brain. That's that whole transtentorial herniation, movement of the brain from one compartment to another compartment where it doesn't belong. Yes. Yeah, it generally tends to be faster, but you would see similar type of symptoms. It would be a little bit more rapid. Yeah, yeah, exactly. You're going to see a lot of the similar types of symptoms because of the herniations that take place when you're pushing the brain and you're increasing the intracranial pressure. You're going to see a lot of these symptoms crossing over. And these are going to require surgical interventions. So we'll watch some videos here. Aside from surgical interventions, you want to reduce the intracranial pressure because intracranial pressure is generally what's going to cause the death in the patient. Right? When you increase intracranial pressure, you're going to increase like herniations and things like that. So that's not a good thing. So you want to give them mannitol infusion, and it's going to allow for diuresis to decrease the blood pressure. You also want to slow down the inflammation, and by doing, you want to give them corticosteroids so you can reduce the inflammatory process. And then if it's really bad, you want to induce coma in those patients. So let's watch some of the different types of treatments that you can do for these kinds of patients. All right, so you get the idea with that. So the reason why I include this image as well is because that's what trephination looks like. Trephination is the term for this old type of procedure, and it's been used for thousands of years. Generally speaking, back in the day, people understood that if you had some severe brain trauma, it's a good idea to try to relieve the pressure in the brain, and often they'll do trephination, where they literally drill a hole in the brain to allow it to relieve the pressure. So kind of similar to what was going on over there with a craniotomy, where they were suctioning out the blood. So kind of similar. You get the creation of an opening to release pressure, and then also suctioning to remove all the blood that was building up in there. Let's watch a larger craniotomy. These videos are really awesome, by the way. So this is epidural hematoma, blunt trauma. 10-year-old kid. Look at that. See that nice lens shape, biconcave, or biconvex rather. So that's all bone right there. So they remove the portion of the cranium, and there's your massive hematoma that can be surgically evacuated. Notice the pulsation. There's a bunch of blood vessels out there surrounding the brain that are going to be. You can see them pulsating. It's really, really incredible. Kind of looks like jam, huh? Look at that pulsation. There's no more blood now. That's basically it. That's how they do a craniotomy to evacuate a epidural hematoma. Put the cranium back on, and that's it. Suture the patient back up. Huh? Blunt trauma. Uh, who knows? Maybe the kid, tripped and banged his head on the wall. Who knows? So 2 hours. That's how long it took. No complications. Yeah. And so the patient survived, happy ending, no neurological deficits. So that was a good story. Now this is for a subdural hematoma. This one is really cool as well. And this one actually has a nice soundtrack to it too, unlike the last one. Older patient, fell, pupils are dilated, severe intracranial hypertension. So with the intracranial hypertension on a subdural, it's going to be more dramatic than what you see in an epidural. Look at that midline shift that you were talking about. It looks much more like a crescent moon when you have a subdural. So there's the skull. They're going to do a craniotomy now. Yeah, Tchaikovsky is a nice touch to this one. So that's the dura right there. That's the dura mater. And so you reflect the dura mater, and then you can see the hematoma underneath. That's the hematoma right there. All of that. Just scrapes right off. And look at that one right there. A nice little leaky vessel. They actually go in there and cauterize it. That's for cauterization. So it sends like an electric signal there, and it just burns it basically. So it cauterizes the vessel, so it shuts it back up. Huh? No, it's better than letting it bleed, right? You wanna close the vessel out. So this patient did get some consequences, right? So she has hemiparesis after the surgery. Yeah, the music definitely gives it some like serial killer vibes. Good stuff. So, any questions on subdural versus epidural hematomas? The epidural? Yeah, yeah. Right. I mean, you want to, if you have trauma to the head that causes a bleed, like an epidural hematoma, that trauma is probably going to be bad enough where you're going to want to go to the hospital anyways, right? And so that's when they'll do a head CT and then they'll see if there's an actual bleed taking place. Yeah. No, no. Subdural usually also is going to be trauma. They're both going to be caused by trauma, but it just depending on what vessels are involved. Usually for epidural, it's going to be arteries, so the middle meningeal artery, versus a subdural is generally going to be those bridging veins. So it depends on which vessels are involved, but they're both usually going to be caused by trauma. If it's a ruptured berry aneurysm, that is specifically a subarachnoid hemorrhage. So that's different than a subdural hematoma. Subarachnoid hemorrhage is going to be below the arachnoid area, right? So that's why it's a subarachnoid. Whereas a subdural is between the dura mater and the arachnoid mater. So different regions of the brain are going to be involved. Different regions of the meninges are going to be involved. Speaking of meninges, let's go into meningitis. So meningitis is, for the most part, a bacterial infection, and it's extremely fatal. Those patients need to be treated as quickly as possible because patients with bacterial meningitis can die sometimes within 24 hours. So it's extremely dangerous. And they usually die because of all the inflammation. The bacteria causes a lot of inflammation in the brain, and the inflammation is usually what kills the patient. So this is a brain from a person who obviously didn't survive, and that's all just like bacteria. All that stuff that's surrounding the blood, that's going to be part of the bacterial infection. It can be viral, but the viral meningitis is not as deadly. Not as bad. Bacterial meningitis, extremely deadly. Viral meningitis is definitely not as bad. There's also fungal meningitis too. Not as bad as bacterial. Bacterial is by far the worst of all of it. So the meninges, to go back into some basic neuroanatomy, is all the different layers that surround and protect the brain as well as the spinal cord. Now you have three layers. You have the dura mater, which literally translates from Latin to tough mother. That's what dura mater means. So it's going to be a really thick, tough layer of protective sheath that covers the brain. Beneath that is going to be the arachnoid mater. So the arachnoid mater is going to be, the reason why it's called arachnoid is because it comes from spiders, right? It looks like spider webs. That's why it's called the arachnoid mater. So if you take a look at the little area that's within the arachnoid mater, it looks like a bunch of spider webs all throughout. So that's why it's called arachnoid mater. And that's where you find, dang it, I'll give you the answer. That's where you find your CSF. So cerebral spinal fluid is going to be in your arachnoid mater, and it can get drained, especially into the middle sagittal sinus, where you have your venous system. And so that's where CSF eventually drains into the venous system. So it goes back into the circulatory system. And then the layer that is going to be completely attached to the brain is going to be the pia mater. So that is your meninges in a nutshell. If you have meningitis or encephalitis or any of those conditions that might have a differential of meningitis, a differential diagnosis, generally you want to do a lumbar puncture, also known as a spinal tap, right? And so when you do a spinal tap or a lumbar puncture on the patient, you're going to go between the third and fourth intervertebral area, right? And the reason why you do that, actually, you guys tell me, why do you want to go specifically in that portion of the lumbar spine? Yeah, it's past the cauda equina. Actually, no, sorry, it's past the conus medullaris. You got the conus medullaris, and you got the final terminale, right? And then you have the cauda equina coming off of the end of the spinal cord. And so if you were to go above, you would be poking the spinal cord, which is not a good thing. So you want to go between L3 and L4. So usually you can tell where it is because you can palpate the posterior iliac crest of the patient, and that the posterior iliac crest is generally going to be associated with that area, L3, L4 of the lumbar spine. So you palpate the back of their pelvis, right? And then that's where you determine where L3, L4 is. And then you go in with your needle, and when you go in with the needle, there's a couple things you can find. So if it's bacterial meningitis, you're going to see sometimes it's going to be cloudy. The CSF is going to be cloudy. When you run an analysis on it, you're going to see increased neutrophil count because it's bacteria, right? So it's going to cause neutrophilia, right? So you're going to have increased neutrophils. And then you're also going to see a decrease in glucose levels because bacteria like to consume glucose. So those are some things that you can run for bacterial meningitis. For viral meningitis, you're going to see increased lymphocyte count because it's a viral infection. You're going to see mostly lymphocytes. So I'll give you a couple. I'll give you like a little slide that shows like the breakdown of things that you'll find on a spinal tap or a lumbar puncture. So where is the needle tip going when you do a lumbar puncture? Yeah, good. So you're going into the subarachnoid space. Exactly. Anyone ever see this movie, by the way, Spinal Tap? If you haven't seen it, highly recommend it. It's absolutely hilarious. It's a mockumentary about a rock band. It's like a mockumentary rockumentary. It's so funny. Very good. Classic back in like the late 70s. It's hilarious. Meningitis. So you mentioned that there was viral meningitis, right? Not as bad. So that is called aseptic meningitis. If it's bacterial, that is septic meningitis. Septic meningitis is really dangerous. It's really bad. The person can die very rapidly. Viral meningitis, not as bad. The person is probably not going to die as rapidly. What are the culprits for viral meningitis? Very commonly, it's going to be HSV2, which is herpes simplex virus 2. So that's the one that causes like the more like genital type lesions. HSV1 is usually going to be perioral. You get like lesions like cold sores in the face. So HSV2 is going to be one of the main culprits. Also Coxsackie virus. When you do the spinal tap, you don't find any bacteria, obviously because it's viral. And then treatment, you can treat this with antivirals. So depending on what the case is, if it's HSV2, acyclovir, valcyclovir, those drugs are very well tolerated and very effective in treating HSV2. And to reduce the amount of inflammation, you can give them corticosteroids. Bacterial meningitis, on the other hand, like I said, very bad. And that's going to be septic meningitis. And the main culprit is going to be the main culprit for pneumonia, and it's Streptococcus pneumoniae. So if you have a patient with pneumonia, especially due to Streptococcus pneumoniae, treat that patient with antibiotics because that bacteria can easily make its way into the meninges, and if it does, that's bad, right? So anybody with pneumococcal meningitis, you want to treat that person with antibiotics to prevent them from getting meningitis. There's other bacteria that can cause meningitis too. So Streptococcus or strep pneumo is the most common. You can also see Neisseria meningitidis. Neisseria as a genus, damn, I should have capitalized. Genus is supposed to be capitalized. So, but anyways, Neisseria as a genus is a Diplococcus gram-negative. Same type of organism that causes gonorrhea, right? But that's Neisseria gonorrhoeae, so it's a gram-negative Diplococcus. Versus strep pneumo, it's a gram-positive Streptococcus, but it also kind of looks like a Diplococcus sometimes. It would be lancet-shaped. If you take micro, you'll learn about strep pneumo in more detail. But there's other bacteria that can cause meningitis, bacterial meningitis too. So it's not just these guys. Another one that you could possibly see, Haemophilus influenza. That's what does Haemophilus influenza usually cause? Do you guys know? Middle ear infection. It's like very common for otitis media. It causes other infections too. But for a child, it's children that usually get that up to about age 5. They'll get Haemophilus influenza. You also want to treat that child for the ear infection because that can also easily make its way into the meninges, right? Think about the proximity of the middle ear to like the brain, right? So if it makes its way to the brain, very dangerous. Another one too is going to be strep A galactiae, and that's one that you see in pregnant women. It's like about 1/4, about 25%. If I remember correctly, it's 25% of all women have GA, group A strep, GAS, which strep A galactiae falls under that umbrella. Children that are born from a mom with GAS have a really high chance of getting sepsis as well as meningitis from that. So it's not just these bacteria here. Lots of different bacteria can cause meningitis. When you treat it, you can prevent it with vaccinations. There's the pneumovax. There's a couple different ones. There's like 23, there's a 23 serotype pneumovax, and there's like, I can't remember off the top of my head, I think it's 12 serotype. There's a couple different options that you can take. It's especially recommended for like old people who live in nursing homes, because oftentimes that's one of the predisposing factors, living in close quarantine with people. And for older people, they're more immunocompromised compared to younger. So older individuals, generally you want to give them a pneumovax injection to prevent that. But if you do get it, of course, antibiotics is going to be how you treat this. And very aggressive antibiotics. You want to give them broad spectrum antibiotics. So like vancomycin, ampicillin, those types of drugs are really important. Cephalosporins as well. Yeah, so when you have meningitis, everything is going to be involved. So you have the pia mater, the subarachnoid space, ventricles where you have CSF. Those are all going to be involved. It is extremely contagious. Risk factors, like I just mentioned, living in close quarters with people. So dorms, barracks. So for those of you who live in dorms, you guys are at a higher risk than the general population. Patients with otitis media, as I just mentioned, with Haemophilus influenza with young kids. Sinusitis, and then sepsis. Of course, sepsis, if it gets into your blood, that can be a predisposing factor. Signs and symptoms. It can start off like a mild cold at first, and then all of a sudden when it gets to your central nervous system, then you get this. This is the biggest one. If you see a patient that has a headache, but then they have stiffness of the neck, that is called nuchal rigidity, and that is a huge red flag that that person has meningitis. So if you see nuchal rigidity or stiffness of the neck, you know that that person probably has meningitis, and you want to make sure you treat that patient rapidly. Depending on severity, you might also get photophobia as well as vomiting. The person could become confused, they can lose consciousness, and then coma and death, right, if left untreated. So those patients can decompensate very rapidly. You can also see deafness too. And here's the interesting thing about it. It's extremely fatal. But if you survive bacterial meningitis, even if you survive, sometimes those patients will still have permanent neurological deficits. Often it's going to be hearing, so sometimes they might actually have deafness permanently afterwards. So you can have permanent neurological deficits afterwards. Viral meningitis, it is more common, but it's not going to be nearly as severe. So here are the things to look for with meningitis. This right here, where you have like petechia and purpura, it's going to be most common in Neisseria meningitis, not so much strep pneumo. So if you have strep pneumo, you're usually not going to see stuff like this. But you'll see that with meningococcal meningitis. So things to look for: high fever, headache, photophobia, nuchal rigidity, stiffness of the neck. And then when you do a lumbar puncture, when you do that lumbar puncture, there's going to be more CSF coming out because the pressure is going to be higher. So you're going to have higher pressure on lumbar puncture. You don't see that as much with the other types of meningitis. You see that mostly with bacterial meningitis. If it's really bad, right, you're going to eventually get seizures, altered mental status, coma, and then death, obviously. The meningococcal type meningitis, that's where you get the petechia type rash, like you see in this little image here with the baby. And then this is what you're going to look for in the CSF. I didn't include fungal in here because I'm not going to make you responsible for fungal, but just know the difference between bacterial and viral. With bacterial, neutrophilia, right? You're going to see increased neutrophil count. The other thing that you're going to see, glucose is going to be consumed by the bacteria, right? Bacteria love glucose, so you're going to see reduction in glucose levels in the CSF. You're going to also see proteins, elevated proteins in CSF, but you're also going to see that with viral, so that's not specific to bacterial. What is specific is neutrophils and then the elevated pressure and glucose. Viral, you're going to see normal glucose levels because viruses don't care about sugars, right? They're not going to be consuming sugars or anything like that. Protein's also going to be elevated, but instead of neutrophils, it's going to be lymphocytes. That's going to be the major key difference is neutrophils versus lymphocytes. The Kernig's and the Brudzinski's sign. So we'll talk about that momentarily. Those are two different tests that can help to determine whether or not the patient has meningitis. So we'll talk about that in a second. So signs and symptoms, we already talked about all that, but lumbar puncture is going to be the most important thing. You're going to see cloudiness in bacterial meningitis, elevated pressure, neutrophil counts, so neutrophilia, proteins, low glucose, versus viral. The lumbar puncture is going to be clear. You're going to see lymphocytes in that analysis afterwards. And then, as I mentioned, most of the damage is going to be due to the inflammation. The inflammatory process is what kills the patient when they have bacterial meningitis. So that's why you might want to consider giving them a corticosteroid to help reduce inflammation along with the antibiotics. Brain swelling, of course, is what's going to cause all that nerve damage. And then you also get clots with the capillaries. So viral meningitis, you're not going to see this as much. Now, what are the physical exams that you can do? There's two physical exams. There's the Kernig's test and there's the Brudzinski's test. Maybe one way to help you remember this is Kernig, you're going to flex their leg with the knee. Right? So Kernig, knee. So with the Kernig's test, you're going to lift their leg and you're going to flex them. You're going to have flexion at the hip. And then at the knee, you're going to try to extend the knee. And when you try to extend the knee upwards, like you're trying to get the person to basically stick their whole leg straight, right, perpendicular to their body, that applies pressure to their spinal cord. And so that pressure is going to cause pain at the meninges. So that's the Kernig's test. If you get pain when you try to flex their hip and then extend their knee, that's going to be a positive Kernig's test. The other test is the Brudzinski's test. And the Brudzinski's test, you're basically you're trying to flex their head, so you grab the back of their head and you try to push it forward. Right? So if you try to flex their neck, that's going to cause pain, and then their knees are going to come up. Right? They're going to actually flex their knees as well. And in so doing, it helps to relieve the pressure when you flex their neck. So that would be a positive Brudzinski's test. Here's another image of what this looks like. So this would be the Kernig's test. They're flexing their hip and they're trying to straighten their knee out. Versus the Brudzinski test, you grab the back of their head, try to flex it forward, and then that's going to elicit pain, and it's also going to make their legs come up, right? So they're going to flex their knees reflexively. Signs and symptoms of meningitis, we basically already talked about it. You get altered mental status, so you get confusion, lethargy, vomiting, nausea, fever, because of course if you have a bacterial infection, you're going to be febrile as a consequence. And for kids, you want to, kids don't talk, right, if they're infants. So you want to be able to, see if there's other things that might be causing it. Other symptoms that would give you a indication that the kid has meningitis. So fever, nausea, vomiting. If they have that rash, it could be a meningococcal type meningitis. If it started from a middle ear infection, when kids have an ear infection, the parents will tell you, oh, the kid's been tugging at his ears. And so that's one indication that it could be from the middle ear infection that could have got its way into the central nervous system. Treatment and prevention. So treatment, you want to give them broad spectrum antibiotics right away. So treat them right away as quickly as possible. When it comes to serious infections like pneumonia, sepsis, meningitis, you start the patient right away on broad spectrums. Eventually, when you get the CNA testing later on, CNS, so that's culturing and sensitivity testing, you get like, the lumbar puncture. You can also do a blood draw too. Send that off to lab. They can tell you exactly what the organism is. So that's the culturing part. So they'll say, oh, this is a Streptococcus pneumoniae meningitis. That you'll find that first. It's usually within 24 hours. You find out what the organism is. But that still doesn't really help you with the treatment. You still want to continue administering broad spectrums. The sensitivity testing comes later on the CNS test, and then you'll find out from lab, oh, what are the drugs that this organism are susceptible to? And so you could switch from that broad spectrum antibiotic. Now you can switch to a narrow spectrum antibiotic. Why do you want to do that? Why do you want to make sure you don't keep them on a broad spectrum the whole entire time when they're being treated? Antibiotic resistance, but also dysbiosis. You're not only going to be killing their good bacteria, but you can kill you're not killing just their bad bacteria, but you're killing their good bacteria too. So you can see C. diff, diarrhea, as a result, right? Clostridium difficile is really bad. So you don't want to induce dysbiosis. So you want to switch to a narrow spectrum antibiotic for that reason, but also for the antibiotic resistance too. These drugs, they're oftentimes like vancomycin. It's one of the drugs of last resort. Unfortunately, nowadays you're seeing a rise in antibiotic resistance against vanc, which is terrible. So MRSA, you guys are familiar with MRSA, right? Methicillin-resistant Staph aureus. There's also VRSA, which is vancomycin-resistant Staph aureus. That's really bad. There's only really one drug that we use to treat those type of patients. It's linezolid. Linezolid is the drug of last resort, and you can only really get it in a hospital setting. Thankfully, we're not really seeing the rise of linezolid resistance, but if we did, that's really scary because there's nothing else that we can really use to treat those types of patients. But these are the major drugs that we use for meningitis: vanc, ceftriaxone, ampicillin. Those are the major drugs. All right, so that is meningitis. Meningitis specifically is inflammation of the meninges, whether it is from bacteria, virus, but also fungi as well. Encephalitis is different. Encephalitis is inflammation of the actual brain itself, okay? Not the meninges. The meninges surrounds the brain. Encephalitis affects the brain specifically. And unlike bacterial meningitis, encephalitis is usually going to be viral. It is mostly going to be viral, and the most common agent is going to be HSV. So herpes simplex virus is going to be the most common one. HSV1 specifically. HSV1, that's going to be more oral, right? Like cold sores, right? Versus HSV2 is going to be mostly genital urinary, right, type of sores. But HSV1 is going to be mostly cold sores. If it gets into the brain, it's going to cause encephalitis. Other ones that can cause encephalitis, it's not just herpes simplex. You get it from other organisms. So mononucleosis, rubella, rabies, polio, all of those are going to cause encephalitis too. Signs and symptoms, you can see increased pressure, so increased cranial pressure, altered mental status, seizures, paralysis if really bad. Generally speaking, encephalitis, when it's viral, it's worse than viral meningitis. Viral meningitis is really not that big of a deal. Usually it resolves in a short period of time. Viral encephalitis, though, is way more serious. Viral encephalitis can indeed kill the patient. So what would you do with the CSF? You would see lymphocytes because it's going to be viral in nature. And if you did an MRI, just like what you see in this image here, you're going to see the areas affected by the virus on MRI. So MRI is going to be a good type of radio imaging that you could do to see which areas are affected. And if it's viral, you can give them antivirals. So acyclovir is a very commonly used drug to treat encephalitis and any other viral infection too. There's a ton of antivirals, but acyclovir is really, really commonly used. You also want to reduce your intracranial pressure. So you could theoretically give them mannitol as well, and mannitol would help to diurese the patient. So to reiterate, HSV1 is the most common cause. It's going to be viral in nature. When you have encephalitis, you get altered mental status. Lumbar puncture is going to be the best way to diagnose, and then as well as with MRI, and treat the patient. You want to treat these patients with antivirals because it is fatal if left untreated. All right, any questions about meningitis versus encephalitis? Cool. You're not responsible for this one, but I put this in here when I talk about things that affect the brain because this one's really interesting. So this is Naegleria fowleri. Naegleria fowleri is a protozoan infection. So this is the brain-eating amoeba. So it's really, really, really fatal when you get this one. And how do you get it? I'm going to be a party pooper here, but you get it by swimming in lakes, right? Especially if you dive into lakes, do like a cannonball, all of a sudden water just rushes up into your nose. What do you have at the top of your nasal cavity? You have like olfactory bulb, right? So you have your cribriform plate and you have your olfactory nerves. If you jump into water that has Naegleria fowleri in it and it goes up to the olfactory bulb, that's how it gets into the brain. And so keep that in mind next time you go on spring break to, a lake and start diving in the water. So I've done that plenty myself too. So, but know that this is potentially something you could possibly get. So Naegleria fowleri, you find it in water. You can also find it in soils too. It's a protozoan, and if you get the trophozoite coming in, that's what penetrates through the olfactory bulb and can be really, really serious. This is how it gets in. It goes in through the cribriform plate, then it gets into your brain, and it starts just wreaking absolute havoc to your brain. So this is what it's doing to the brain. It's causing some serious damage to the tissues, neurons. You got breakdown of tissues. And this is what it looks like if you were to look at it underneath the microscope. So this is sped up.
Naegleria fowleri trophozoites isolated from the cerebrospinal fluid or CSF of a patient with primary amoebic meningoencephalitis are seen with phase contrast microscopy at 600 times magnification. The amoebae are seen moving in a sinuous fashion at about 10 times their normal speed.
So when amoeba move, they usually stretch a little section out. That's called a pseudopod, pseudopodia. So it's like a fake foot. And then they grab and they pull. That's how they move. So that's when you hear amoebic type movement, that's what they're referring to. And so that's how those are going to be running around in your brain, causing all sorts of chaos and damage. What's up? Yeah, that's a blood smear. Those are all neutrophils. Yeah, for whatever reason, there's a lot of neutrophils involved in here. Yeah, that's a good point. These would possible these are eosinophils. Because eosinophils are going to be more associated with parasitic type infections. But they look like neutrophils. Yeah, I don't know. That's a really good question. So, but that is a bunch of leukocytes, regardless. This is all close to home, right? So this actually happened here on the border of Arizona and Nevada. So this kid was vacationing with his family, jumped in the water in Lake Mead, and the Naegleria fowleri got to his brain, and eventually it killed the poor kid. This is not so close to home. This is in the UK. These are the Roman baths. They've been shut down since the 1970s because of a lot of Naegleria fowleri within those waters. And so people used to be able to swim in those. Nowadays, nobody's allowed to get into those waters because lots of parasites in them. How do you treat it? You can treat it with a lot of different types of drugs. Some of these are antibiotics like azithromycin. Fluconazole is an antifungal drug. So lots of different drugs you can use to treat Naegleria fowleri. And to reduce inflammation in the brain, you can give them dexamethasone, corticosteroid type drug. So that's all I have for you for Neuro Part 1. Let's go ahead and do some quizzes questions. I made quite a few, so there's 20 questions here. I'll determine whether or not I actually want to get through them all today, or if we should just get into Part 2 of Neuro, because there is still quite a bit of ground to cover. All right, let's go ahead and begin. So with these types of patients, one of the differential diagnoses is ADD. So attention deficit disorder would be considered one of the differentials. So you could work that patient up for ADD, but the rest of the clinical vignette is more in line with petit mal seizures. With a petit mal seizures, that's the one where it happens pretty rapidly, and it happens to like younger individuals, and it happens pretty quick, right? So it's usually going to be less than 20 seconds, and they're just staring into space. They go kind of blank, but it happens pretty quick. Does it give you? Yeah, so the event lasts for a few seconds. So a few seconds is the key giveaway. If this was a partial seizure, it would last longer than that. So this would not be in line with a partial seizure, mostly due to the duration of the effects. What's up? That's a really good question. Let me actually look that up real quick. So the question was whether or not petit mal seizures will actually go on into adulthood. No. It's uncommon for absent seizures to continue into adulthood, but it's possible to have absent seizures at any age, and that's according to Johns Hopkins University. So generally speaking, it's going to resolve over time. There are certain seizures that you get when you're younger. So febrile seizures can predispose you to getting seizures into adulthood. And there's another type of seizure that I can't remember the name off the top of my head. I don't remember the name for it. Oh, Lennox-Gastaut seizure. Lennox-Gastaut, that's what it is. I couldn't find it on Google search, but I remembered it. So Lennox-Gastaut seizures are the ones that can happen to young kids. We're not going to talk about those for this class. You're not going to be responsible for it. But those are really bad because those, if left untreated, can cause permanent neurocognitive deficits in that child. That child can grow up to, have be mentally incapacitated to a certain degree. So that's a scary one. But yeah, febrile seizures you can get into adulthood, like it can predispose you to getting epilepsy later on. But yeah, usually petit mal seizures only affect children. So that was a pretty easy question. If you have a unilateral headache that's going to affect your eye, and it clusters in like multiple episodes throughout the day, that's going to be your quintessential cluster headache. So looks like most of you guys got the correct answer on that. So let's move on. All right, so let's see what happened here. Oh, whoops, really? So on your end, the circle's moved over. Oh, that sucks. Okay, well, sorry about that. I don't think there's any way I can really fix that one. So just keep that in mind if you revisit this question. But you guys got the point with this question, right? So you saw lymphocytes. So if you see increased lymphocytes on the lumbar puncture, that's going to be what? Viral or bacterial? Viral. Good. So if it's viral, that's going to be considered an aseptic meningitis. If you saw neutrophils, that would be aseptic meningitis. What? Yeah, the vignette is kind of weird. It said that it was cloudy a little bit. On average, it's going to be more clear. Yeah, yeah. I didn't. I was considering not using that question because of that. Yeah. So I wanted to mention also the last vignette. I was considering not using that other question regarding the aseptic meningitis because it talked about how the CSF looks cloudy. I don't like that question because of that. I didn't write that question. So generally, I want you to associate viral meningitis when you do the lumbar puncture. I want you to associate that with a clear CSF. Okay. Generally speaking, if it's cloudy, you're thinking more bacterial or septic meningitis. I don't like that question. So for the exam, I wouldn't trick you with that. I would make it more clear. So you would see clear CSF, lymphocytosis, right? Increased lymphocytes. Yes? On the what? Um, yeah, if the patient has a fever, you're going to think febrile seizure. Yeah, yeah. Don't worry about the cutoff limit, right? So that's like when you get above 102, that's when you should really start getting a higher risk for febrile seizures. But for kids, they have a low seizure threshold in general. So whenever they have a fever, they're going to have more of a risk of getting a febrile seizure. So is that why a lot of you thought that this was a grand mal seizure? Was it because of the temperature cutoff? Oh, okay. So if you see a young kid and they have some sort of like infection, like a respiratory tract infection, I want you to associate that with a febrile seizure. Okay? And a febrile seizure is going to look like a general seizure. It's going to affect the whole brain. What was your question? It's the difference is that a grand mal seizure. We don't really talk about grand mal seizures. We when we diagnose somebody, it would be like grand mal epilepsy, right? Grand mal epilepsy, grand mal seizures, right? This would be a person that probably had that multiple times and wouldn't be necessarily a kid. Because usually when you diagnose a person with like epilepsy, they have to have a couple episodes. When they're a kid with an illness, that's just like a one and done type of scenario, right? So just think about it as just like a young kid, infection, high temperature, they get a seizure, that's a febrile seizure specifically. So you wouldn't classify that as a grand mal seizure, uh, even though it looks a lot like a grand mal seizure. But in terms of classification, it's specifically due to the temperature increase. Does that make sense? Is that why you thought that it was grand mal? Oh, okay. Yeah, so febrile seizure, if you see a temperature in there. So the prodrome, how long does that last for? Prodromal period? Yeah, it can last a days, right? And so you're going to get maybe some mood changes. Maybe the person might be feeling a little bit depressed, right? So those are the days leading up to the actual event. Then before the seizure takes place, that's when you have the aura, right? And the aura is going to involve things like different types of like hallucinations. You could see things, maybe you could smell things, maybe you could taste things. That's all going to be part of the aura. People who have epilepsy, after they have several seizures, they can identify those triggers, or not triggers, but they can identify when they're about to go into a seizure because they all of a sudden start experiencing those auras. And then you have the ictal phase. And the ictal phase for a grand mal seizure is going to be subdivided into the tonic versus clonic phase. Tonic means tonicity, or that's not a good way to say it because tonicity could deal with like electrolytes and stuff. Tonic, think about it as being like you're tensing up, right? So you have flexion of the muscles, rigidity. That's going to be the tonic phase. And then the clonic phase is where you have the uncontrolled jerking movements. Right? So that's why it's called a tonic-clonic type of seizure. So tonic, stiffening, clonic, jerking movements, uncontrollable jerking movements. Then when everything is done, you go into the post-ictal phase. And then at the post-ictal phase, that's when you are just drained, right? So you can get lethargy, you can get confusion, right? The patient now, they basically used up all the energy that they had in their brain, right? And now they're just exhausted. Now they just have to sit there and try to recharge and get some rest so they can feel better again. Was it? Yeah. Yeah, that makes sense. Yeah, that would like loud sounds, flashing lights, right? So flashing lights for people with epilepsy, that's a huge trigger. So yeah, I guess it would bypass the whole prodrome. I would imagine so. I mean, maybe they had a prodrome that they weren't aware of leading up to it. I'm not sure. Yeah, that's a really good question though. I'd have to look into that. So the question is, if you have epilepsy and then you're exposed to like extreme stimuli, right? So his friend was doing a fire drill, and the sound of all the alarms is what triggered it. So yeah, so stimuli could trigger it. So I guess you could bypass those first portions, right? The prodrome and the aura, and just go straight into the seizure. That happened to a friend of mine at a concert. She was at a concert, and all of a sudden she started seizing. That happens to people when if flashing lights is one of their stimuli, right? One of the triggers. I guess you could bypass the first part, but generally speaking, it's good to be aware of just the general uh, progression of a grand mal type seizure. So complete involvement of one side of the face. If you have complete paralysis of one side of the face, you're thinking more along the lines of Bell's palsy, right? So it's going to be involving upper quadrant of the face, eyes, eyebrows, forehead, as well as the lower quadrant of the face too. Most of you guys got that correct, so that's awesome. What's tic douloureux? Huh? Tic douloureux is the French term for trigeminal neuralgia. So douloureux means painful. I don't know what tic means in French, but it's trigeminal neuralgia. So this is a classic example of simple partial. So she doesn't lose consciousness. She's aware of what's going on when it happens. There's really no postictal confusion afterwards. So that is a simple partial seizure. So good job on that. So key giveaways here. The stabbing pain is one term. Some people describe it as like an ice pick jabbing into their eye. The lacrimation, rhinorrhea, ptosis, all of that. So that's a cluster headache. So most of you guys got that correct, so that's awesome. Should not have made that 1 minute long. That was way too long. So once you get towards the end of that vignette, it's kind of obvious what was going on. So the tongue biting, all that, made it pretty obvious. So, and the fact that they were disoriented and confused afterwards, so they had the post-ictal phase, no recollection of the seizure, so total loss of consciousness. So all of that just points towards a grand mal seizure. So this one's a little bit more complex, right? So this is not a simple partial seizure. It's a little bit more involved. And so don't be thrown off by the deja vu sensations, because you can get deja vu sensations actually in both of the partial seizures. You can get it in both simple partial, and you can get that in complex partial seizure. But this patient's seizure was a lot more intense and more involved than it would have been if it was a simple partial seizure. Um, let's see. She is aware of her surroundings, but she cannot control her actions. It lasts for a while and then eventually resolves. She does get a little bit of post-ictal confusion. So she gets a little bit of a post-ictal state. As a simple partial does not have post-ictal confusion during the seizure. They also don't get, any sort of like loss of consciousness. They don't get the memory loss and all that. They do get the deja vu sensation, but it's a lot. The other symptoms are much more minimal. And simple partial seizures, less than 1 minute versus a complex partial, it takes a little bit longer. So it can go up to 2 minutes long. And so that's what happened with this patient. Her seizure lasted, where is that? For about 2 minutes before spontaneous resolving. So duration of time can also give you some hints as to what it was. Any questions? All right, let's move on. So key giveaway here is throbbing, unilateral, photophobia, phonophobia, all those things are all going to be part of a migraine headache. So most of you guys got that correct. So let's move on. Let's speed things up here. I want to get through these questions. So all of these are triggers, right? Every single one of them. Stress, caffeine, foods, lack of sleep. All triggers for migraines. End it again. So pretty straightforward question. Just know if you rupture a barrier aneurysm, that's going to result in a subarachnoid hemorrhage. That's a softball question for you all. So key findings: biconvex lens shape hematoma. When you see lens shape, you're thinking epidural hematoma. So good. Most of you guys got that correct. So subdural hematoma, when the vessels that are going to be involved for the most part are going to be the bridging veins. Most of you guys got that correct. It's fantastic. I need to fix that middle. I'm going to put that middle meningeal artery. I should probably correct that just to throw that in there, because middle meningeal artery is going to be the one that is most commonly associated with a epidural hematoma. So I just corrected that instead of middle cerebral artery. Middle cerebral artery is going to be the most commonly involved in like stroke. And I'm sure most of you guys got that correct because I just told you what the answer was, basically. So the middle meningeal artery is mostly commonly associated with epidural hematomas. So perfect. All right. So this is a classic case of meningitis, right? And then when you look at the lumbar puncture, the analysis, you see lymphocytosis. That is going to indicate a aseptic meningitis. So that's a viral. If you saw neutrophilia, or sorry, neutrophil count, then that would be bacterial. All right, which one does what? Who wants to describe the Kernig's test? Flexor hip, try to extend the knee, right? So that would elicit pain. What about the Brzezinski test? Someone want to describe that? Yeah, put the head on the back of the head, flex it forward, and then you're going to see their knees come up, right, as a consequence. So that would be a positive Brzezinski's test. Let's do two more, and then we'll begin the second part of neuro. So meningitis is pretty easy. Literally, if you see a meningitis question, just go to the labs, really, and you see what the labs look like. Right? Neutrophils in the CSF and higher pressure on lumbar puncture. Those are all the things that you would, would give you a key giveaway that it's bacterial meningitis. So let's do one last question. Meningitis, inflammation of the meninges. Encephalitis, inflammation of the brain itself. Meningitis, it's really bad if it's bacterial, but it can be commonly viral as well. Encephalitis is going to be mostly viral. There's other things that can cause encephalitis too, but it's mostly going to be viral. And encephalitis can kill you too. That's one other key thing that you want to keep in mind. All right, any questions on part one of neuro? So I divided neuro into 3 parts. Part 1, part 2, which we're going to start right now, as well as a part 3, which I'm going to post later. Part 3 is going to be easy. So next week is your exam, right? So next Friday, you guys are taking your second exam. All the stuff that we're covering, cardio, neuro, all that stuff is going to be on the next exam. On next week, we're going to do part 3, and it's all behavioral health. And psychiatry is pretty straightforward stuff. So it won't be as much material. The bulk of the challenging material comes from parts 1 and 2 of neuro. Let me get into part 2. So part 2 is going to be fun. We're going to talk about all sorts of neurological disorders like dementia, Alzheimer's, Parkinsonism, Lewy body dementia. So those are all going to be part of this next series on neurology. Has anybody seen this movie? I saw this movie a lot when I was a kid. This is like part of my childhood. And I actually forced my wife to watch it the other day. It's a great movie. It's like Arnold at his best. He does the whole like thing, you know. We're watching. It's like, damn, he actually does that. It's hilarious. So very good film. So these are the things that we're going to be covering in part 2. So we're going to talk about the different types of dementias. We're also going to talk about some neurodegenerative disorders like ALS, and then we're going to talk a little bit about myasthenia gravis and what that looks like. So let's start first talking about dementia. Dementia affects a lot of people, right? My dad was diagnosed with senile dementia 4 years ago. So yeah, it was terrible. We had to like start getting like caretakers and stuff. This is like when his like partner at the time was still alive. She had dementia as well. So they both had dementia, and it's really tough on families. It's tough. It was tough on me. I had to go there all the time to like help them like fill their meds and whatnot. And so it's a huge, it's a huge burden to everyone involved, right? There's family members, society at large. So it's a tough thing to deal with, right? And unfortunately, it happens to a lot of us. There's normal senile type dementia, but there's other types of dementias too that are like more, that are worse, right? Like Alzheimer's dementia is definitely worse than senile dementia. Parkinson's dementia is terrible. Lewy body dementia is also really terrible. So these are all difficult things that we as a society have to deal with, especially now we have an aging society, right? We have more geriatrics nowadays. And it's good because that's a consequence of like good modern medicine. We've been able to increase longevity of patients, make people live longer, but at the same time, it's also going to increase the rates and the incidence and prevalence of patients with dementia. So lots of people were diagnosed with dementia in 2015. I should probably update these stats, but it's estimated that you're going to have lots more patients with dementia by the year 2050. Every 6 years of age, when you're older, every 6 years, you're going to double your rates or double your likelihood of getting dementia. Dementia is very expensive to address, right? Because you have to deal with long-term adult care, long-term care facilities, group homes, retirement centers, etc. So huge expense, right, as a society. And age, of course, is going to be one of the major risk factors for dementia too. So here's a picture of a stereotypical patient with dementia. Moving on. So activities of daily living. This is one of the first things that you start seeing being affected by dementia. You're going to start seeing your ADLs being affected. And so like for my dad, for example, my dad and his partner at the time before she passed away, their activities of daily living were hugely impacted. They had a hard time getting anywhere from place to place. They had a hard time getting dressed. They had a hard time bathing. They had a hard time just basic hygiene, things like that, right? So these are your activities of daily living. So bathing is going to be one of the major ones. Getting dressed is going to be another one. Grooming, oral hygiene, using the toilet correctly, right? All that stuff will fall under activities of daily living. Instrumental activities of daily living will be things like, getting around town, like shopping, cooking, prepping your meds and drugs, things like that. So these are all things that I had to help my family with when they were living more independently. Now my father lives in a group home, so thank God he has nurses there to help take care of him. He's also got really great caretakers to help with all these different things, getting dressed, using the restroom, etc. So all these are going to be impacted by dementia. So normal aging, you are going to over time lose ability, right? Just normally. That's just a normal part of getting old, right? Yay, right? And so that's going to be referred to as like senile type dementia, right? So you might forget some things. You might, have a hard time retrieving words. So all that kind of stuff might fall under like senile dementia. But here are some things that you will see. The patient is actually concerned about their memory loss. That's a good sign, right? If the patient is aware that they're not really functioning as well as they used to, that's a really good sign. That means that they have some insight into their own condition. They might have a little bit of a difficulty finding words, but it usually they don't usually lose their way around. So if they're like driving around town and they know where they're going, they're usually not going to get lost. So those are all good signs that the person is just having some normal cognitive deficits, just typical of normal aging process. It becomes concerning when they don't have insight, they're forgetting things all the time, but they're not aware of it, but their family members are starting to notice. So once you have family members becoming concerned about the person's memory loss, that's a bad sign. That means that this person is probably like getting into Alzheimer's type territory. Getting lost when they're driving around. That is so typical of patients with Alzheimer's. They'll drive around and they'll just completely get lost. I've had this happen to family friends where like their grandma or their mother will just get lost and they're like calling the cops to try to figure out where the hell they went. And eventually the cops find them, but they're like in some weird part of town that they usually don't go to. So those are things that you will see with actual like severe dementia. So much worse than just normal aging. And then it's good to distinguish delirium from dementia. Delirium is going to be acute. It's going to be short-lived, and it's usually going to be due to infections. It could be due to meds, drugs. It could be due to vascular issues. It could be due to post-surgery stress, and it's going to be transient. Usually it happens rapidly, you get delirious, and then eventually you're going to return to baseline. Versus dementia, that is not temporary. That is not acute, and it's going to be chronic at that point, right? So Alzheimer's, chronic. Huntington's, chronic. We're going to talk about Huntington's later. It's so sad. And it's not normal, right? This is beyond just senile, just getting older, right? And it's going to be progressive. You'll see memory loss, both retrograde and anterograde. Generally speaking, you're going to lose more of your anterograde memory. Anterograde is like stuff that you just learned, right? So like if you literally forgot everything that I just said over the past hour, that would be considered like a more anterograde memory loss. But retrograde is stuff that happened years ago, like especially significant memories that you have, right? Even like patients with pretty severe Alzheimer's, sometimes they'll still be able to tell you stories of like way back in the day. Like I had a neighbor that was a veteran from World War II. Guy had really bad anterograde amnesia. He would forget things, but he would be able to tell you so many crazy cool stories of when he was like back in World War II. Like amazing recollection of stories and things that happened in his past. So those are different types of amnesia. But if you lose your retrograde memory, that's very serious. At that point, it's like kind of getting towards like end stages. Like that's when like a parent starts forgetting their kids, that's really bad, right? That would be severe retrograde amnesia. And with that, let's go ahead and continue with Alzheimer's when we meet up on Friday.